Hello. Um, I am doing my assignment this week over the schizophrenia video. Some of the questions that we are asked to overview about this video this week, the first one was, what signs and symptoms did the client or therapist address that led to diagnosis? Some of the things that I had made some diagnostic notes about were the fact that the client had been anxious since she was in third grade. She was a good student, but she often had anxiety. She was shy and fearful. She didn't have very strong friends, but she did have close relationships with her sisters. She was a triplet. Um, her symptoms didn't really appear until after her mother's suicide, who coincidentally was also diagnosed as schizophrenic. The first year was reported to be okay, but the second year she started to get symptoms like her mother had. That she was more paranoid versus her mom's set of schizophrenia. The mother did have a diagnosis that they shared of schizophrenia. The client was 16 whenever the mother did pass away. And that summer was whenever she started having some thoughts that the government was kind of controlling her mind. Dad did notice and he did try to help her, get into some treatment. The little the client heard a voice of a little girl, and it often sounded like the little girl was like scared too. So it wasn't like her voices brought her any type of comfort. If anything, she said that it made her more anxious, or that the child was actually annoying. I thought that was something to kind of note because it kind of gave me a different insight on like they're not always there for comfort, like they're alter personalities, or should I say intrusive thoughts? I apologize. Um, so the markers though that led to the diagnosis in the DSM, the symptoms that she had was that she was experiencing hallucinations and delusions at the same time for a period of more than 1 month. And so she does meet the criteria to be schizophrenia. She also met the duration that her symptoms had continued to appear. It said, what differential diagnosis would you consider for this client? This one kind of perplexed me. So, I would love some feedback if I'm not in the right direction here. Something that I noticed even on the after talk between the clinicians was that it is a little significant for her to have some most of her symptoms start at the early age of 16. Schizophrenia is typically early adulthood, and they say that women is usually a couple years later than men. So due to that marker, I did go ahead and put that it was a possibility to be schizotypal personality disorder, because the difference in that is she would still have her odd and eccentric behavior, unusual thinking, not having very good close relationships, and like distorted perceptions, especially when it comes to the intrusive thoughts of the government and the little girl, and then her anxiety kind of more introverted. And the biggest difference that I could understand between the schizotypal and the regular is that this is more onset in childhood and it says less severe. And so that's what we did see with our client, is that she kind of was at a really good remission spot with her symptoms only occurring for about an hour at a time. Any comorbid diagnosis that might be present. I'm just going to go off of what the um, clinicians in the end of the roundtable talk had talked about there being some possible bipolar schizoaffective in there because of her suicide attempt with her depression. However, I do like whenever we did go talk about, that she wasn't really suicidal. She was just looking for help, but she didn't know how to get it. I like that the clinician was talking about using the rated dimensions of psychosis to figure out the symptom severity and how long, like how can we measure the degrees of those cognitive factors to play into it just being a symptom or more of a pattern of behavior. The specific techniques that I liked about the therapist, I felt like he was patient and he kind of used fluidity with his questions to continue the conversation with the client. I think that he used positive body language to also reinforce and encourage her to continue talking. I think maybe whenever she could have paused on her own. I like that he restated and clarified timelines to allow her to go back and make a degree advocation for when her symptoms started, how they progressed, and how she's handling them now. I think that he allowed her to have her own insight for her treatment and to kind of advocate for what had been working so far with her treatment modalities and what didn't work and where she was at. Um, he reframed with clarifying questions. I saw that he empathized with emotion and that he validated the client's experiences. One of my favorite things, too, though, is he was exploring some medication questions with this client. I know that, there's a fine line between medical clinicians and our mental health clinicians. However, we do find so often, especially with the schizophrenia diagnosis, medication adherence is often not tailored to, which creates the subset of symptoms starting back over, and we kind of have to continue to play that catch and release game. And then I also like that he circled back around to the questions about medication or even to the questions about how the government affected her thinking pattern. I can appreciate that he noted that that was something of importance, but instead of derailing her in the middle of conversation, he just circled back to that. Anything that I would do different in this diagnosis? Um, I think the diagnosis is a good diagnosis. I don't have any problems with the modalities that we got to get there. I think that I would like to see the clinician provide more emotional comfort and not be as clinical when it comes to the questions about suicidal ideation. Maybe just a small pause of saying, like, I can imagine that was a very hard time for you, or, maybe even just something along the lines of, acknowledging what a hard time that could have been. I don't like that it was just blown over, especially when the client seemed to use that as her marker for seeking out help. I think it would just be important for her to feel very heard in that time. And then, um, she also quoted the client and said that I didn't know it was an illness. I believe that also in that moment, it was kind of like a moment of clarity, but also a moment of I just didn't know. And I believe that there could have been some positive reinforcement around that thought process because I can imagine that carrying around the label of schizophrenia and like the craziest of the diagnosis can make you feel a little stereotypical of yourself. I like how one of the clinicians was talking about how in their practice they deal with some of the schizophrenic diagnosis and they do a reality test and they assure the clients. They do an examine and inform. They don't do surprises with their clients and they offer consistency. I just enjoyed having that insight to perhaps, work with a client and apply these things to achieve rapport. That is something that I'm finding in practice right now is that you definitely have to have an idea of their mental health and their communication tactics and their barriers within those diagnosee, I don't know which one's correct, um, to kind of figure out how to communicate with them and what's going to work with your treatment plan with them. And then yeah, I think also something that I learned at the very last of this, it was talking about reading into subliminal messages from the client. I believe that definitely comes with some time and experience whenever you're not so nervous about covering the bases and checking the boxes. However, I think if we can look into their messages and, how they've broken down their own treatment plan like the client did, then we can maybe see a little bit more into like where they're at with their holistic mental health. Thank you for your time this evening, and I hope you have a good week.